I'm going to take you through chronic heart failure. Welcome this morning. I'm Dr. Joan Kiyeng. I'm a cardiology fellow in Moi University. And this is going to be my presentation outline. We are going to start with defining what heart failure is, and then classification as well. And we will look at etiologies of heart failure and pathophysiology, clinical presentation, and diagnosis management, and we will conclude this. And just to define heart failure, what I want you to take out of this class today is that heart failure is a clinical syndrome. It's a clinical syndrome that results from either structural or functional abnormalities. So sometimes the cardiac structure may be normal, but there is functional abnormalities. And that results in inability for the heart either to fill or eject blood. So those are the two things that happens. The heart may not be able to fill or eject blood. So either of the two, you don't need to have the two of them to say somebody's in heart failure. And there is many classifications of heart failure, but what is currently being used is based on the left ventricular ejection fraction. So previously we used to have two classes, only heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. But then over the last few years, they've come up with another classification of heart failure with mid-range ejection fraction. And these are patients who they don't fall, their ejection fraction is in the middle between 40 and 50%. And most of the time, whole heart failure, even if a patient has heart failure with preserved ejection fraction, over time they start developing heart failure reduced ejection fraction. So there are other classifications as well. For example, you can have right heart versus left heart failure, and also you can say diastolic versus systolic. But what is being used now in many guidelines is based on the left ventricular ejection fraction. So this is what you will be expected to know. And just for the definition of the three heart failure. So if somebody is having heart failure with reduced ejection fractions, what you need for all these heart failure, you just need somebody to have symptoms. They may or may not have the signs of heart failure. And of course, symptoms is what you elicit from the patient, and sign is what you observe as a doctor. And if the patient has, if you do an echo and the patient has left ventricular ejection fraction of less than 40%, as you can see here, then that is enough for you to say this patient is in heart failure. You don't need any other classification. You only need the symptoms, plus or minus signs, and the fact that on echocardiography or on imaging, you get a patient having less ejection fraction of less than 40%. So for the mid-range, this is between 40 and 49%. So for these ones, you need symptoms plus or minus signs, and you need to demonstrate a left ventricular ejection fraction in this range. And they also have to have elevated natriuretic peptides, what you call the NT-BNP or BNP. We'll see this later. And at least one other additional criteria, that there has to be relevant structural heart disease. For example, patients who have heart failure in this range, they may not have abnormalities in left ventricular ejection fraction, but they may have dilated left ventricular left atrial enlargement, just meaning that probably they're having diastolic. The left ventricle is not able to relax, and because of that, it results in the left atrium not being able to empty. And then because of that, it starts becoming dilated. So left atrial enlargement. And in this other range, it's almost similar for heart failure. Sorry, I think this was supposed to be H, heart failure with preserved ejection fraction. So it's the same way that you will diagnose heart failure mid-range ejection fraction. You also need symptoms and signs. Symptoms plus or minus signs, and then the LVEF has to be more than 50%, and then you need to have elevated natriuretic peptides. These are just markers of heart failure. And also you have to demonstrate there are some structural heart disease. And the reason for this is because if you have ejection fraction of 50%, you know, for you to really say this patient is in heart failure, you need to really further demonstrate other features, because this is more of a relaxation problem, what you call the diastolic dysfunction. So you have to demonstrate that there is a way you can demonstrate diastolic dysfunction in the echo, or you may actually observe what we say that there should be some element of left ventricular, left atrial enlargement, or even left ventricular hypertrophy. And going to the etiologies of heart failure, there are quite a number of etiologies, and I've tried to simplify them for you guys into three. And the first one is if somebody's having diseased myocardium. So if the myocardium is diseased, and we know there are many things that can make myocardium to be diseased. And on top of the list, which is even becoming more prevalent in our setup than before, is ischemic heart disease, those patients who are coming with acute coronary events. So because of that, they get diseased myocardium. We also see a lot of toxic damage, especially from alcohol. Alcohol, especially among the young people who are taking these local brews in large amounts. We encounter in our setup many patients coming with dilated cardiomyopathy just because of alcohol, and these patients are in their 20s. And also don't forget medications that can cause damage to the myocardium, especially the cancer medication, the doxorubicin, all those anthracyclines and other cardiac medications that are, and even other, apart from the cardiac, there are other medications also that are toxic to the heart, apart from the chemotherapeutic agents. Also, it can be immune or inflammatory mediated conditions such as lupus, erythematosus can cause damage to the myocardium, sarcoidosis, and which can fall under infiltration. So you can also have malignant infiltration of the myocardium and metabolic derangements. On top of the list here is thyroid disorder. So you have both hyper and hypothyroidism can cause myocardiac damage, and nutritional insufficiency. And also you can have genetic abnormalities such as hypertrophic cardiomyopathy. For the abnormal loading conditions, here we are just talking about things that can increase the afterload and really make the ventricle to have to work hard. And these are conditions such as hypertension. It can be valve disease. For example, aortic stenosis is one of those who really makes the ventricle get tired. And even if you have recalcitrant lesions, you have this all volume coming down back to the ventricle, and the ventricle has to work hard to squeeze. And of course, initially it does well, but as time goes by, the ventricles start failing. And there are some pericardium pathologies, for example, constrictive pericarditis, and also endomyocardiac pathologies, and high output states, and simply volume overload from many factors. The other thing you need to consider is the arrhythmias. Patients who have tachyarrhythmias because of the inability of the heart to have enough diastolic time. Also, they start getting heart failure, and also bradyarrhythmias. Sometimes patients with heart block present in heart failure because of the inability of the ventricle to either eject blood, and because of that, it starts failing. So I just wanted to take you back. I know you came about this when you were doing physiology, and the normal cardiac physiology is for you to get a mean arterial pressure. You have it is equivalent to cardiac output and systemic vascular resistance, and this cardiac output comes about from heart rate times the stroke volume. And we know the heart rate is controlled by the autonomic nervous system. The sympathetic nervous system is the one that increases your heart rate. And this is what, like if somebody is exercising, this is what you get elevated heart rate because of that sympathetic nervous system. You at that time you get parasympathetic. The sympathetic one is the driver, and that is why you get increased cardiac output, and when you are exercising. And for the stroke volume, it is equivalent to three factors: the preload or afterload. The preload is what the blood coming back, the venous return coming back to the heart, and the afterload is the blood pressure, the resistance basically. and now the contractility. So the stroke volume is dependent on these three factors. And we all remember, I hope you remember about the Frank-Starling law of the heart. Can somebody take me through that? Frank-Starling.
Morning, Doc.
Morning.
I'm Steven. I was thinking that, okay, I don't remember the exact law,
Yes.
but it has a concept like the more the heart gets filled with the blood, the stronger the contraction will be eventually, up to a certain limit when the ventricular muscles cannot take the stretch anymore.
Okay, that is very good, Stephen. So basically, that is it. It depends on the stretch, on the stretch of the sarcomere. So if you have a preload, this is the tension, and then this is the stretch. So as the stretch comes about because of that preload. As the venous return increases and the myocardium is getting strength, then it becomes more and more stronger. As you can see, D here, the higher the stretch, the stronger the contraction. And that is how the venous return. Of course, it reaches a certain limit, as Stephen said, that it cannot be able to compensate. And that is why initially for people who have regurgitations, for example, mitral regurgitation or aortic regurgitation, initially they usually, even when we are looking at their left ventricular ejection fraction for regurgitant lesions, we want them to be even more than 60% because we expect that the ventricles should be outperforming, and this should be the Frank-Starling mechanism that we expect. But when we see somebody with mitral regurgitation and their left ventricular ejection fraction is in the 50s, we already think they have already started failing because their cutoff is usually higher at the 60s. And this is the same as I was telling you, when somebody is, this is like somebody who has a depressed myocardial function, and this is somebody who is in heart failure. So this ventricular performance is dependent on this ventricular end-diastolic volume. And of course, end-diastolic volume comes about once you already have the atrial kick and the mitral valve is already closed. So now, as you can see, this relationship is going up as you expect the volume to increase, like during exercise, the contraction is more stronger. But in patients who have heart failure, they are not able to compensate like this. And in fact, for them, as they get more volume, they start going into heart failure. And that's why somebody would tell you that they are not able to tolerate exercise. And this is how this heart failure, you may ask yourself, how do heart failure reduced ejection fraction comes about? Initially, when you have damage to the myocardium, the myocardiums try to adapt so that it's able to perform. So initially, because of the adrenergic system, the sympathetic nervous system, or what we call renal angiotensin-aldosterone system, which is basically the neurohormonal axis, it tries to increase the heart rate and initially tries to increase contractility, and also they try to compensate by making the heart hypertrophy, as you can see here, and increasing the left ventricular end-diastolic volume. But then as this goes by, it starts remodeling, because you will see the next slide that also these neurohormones are not the best. And that is why when we are treating patients with heart failure, you see us using things like ACE inhibitors, which you are trying to kind of block this pathway, because in further down the line, it starts causing the heart to remodel. And as you can see here, as the ventricles start dilating and it starts becoming thin. So at the end of the spectrum, you see somebody's having dilated cardiomyopathy, and this ventricle is already failing. It's unable to compensate. So initially, the ejection fraction is good, but as time goes by, and the reason for this is because, as I told you, these neurohormones, they start dysregulating the myocyte gene expression and causing apoptosis. And that is what eventually happens. And this is the short term, as mentioned, compensatory effects. of the RAS system, renin-angiotensin and aldosterone system. Initially, if somebody gets start producing a lot of norepinephrine, and then it increases the heart rate and increases contractility. But as time goes by, it causes ventricular hypertrophy and apoptosis and arrhythmias. And for angiotensin 2, it starts also initially causing vasoconstriction. And you need, of course, vasoconstriction to generate blood pressure and also to improve your venous return. And also causes sodium deabsorption. So it's expanding the blood volume and making the ventricle, of course, using the Frank-Starling mechanism contracts stronger. But then in the end, it started causing cardiac fibrosis. And for the aldosterone, you have sodium deabsorption, and also it's one of these that causes a myocardial fibrosis. So these are good hormones initially, but as time goes by, it causes maladaptive effects. And these are the three key things that we try to counteract when we are treating patients with heart failure. And for heart failure to occur, you would need a kind of interplay between different factors. And one of the factors here is these are risk factors. And we'll discuss this further in the next slides, where you have things like hypertension, obesity, diabetes, and valvular heart disease. I think we see a lot of this in our setup. I'm sure you've come across in the wards, and also coronary artery disease. So because of this, these risk factors start making the ventricle to remodel, the heart to remodel. And let's say if somebody gets myocardial infarction, and they can either get arrhythmias and die, or the ventricle might fail completely depending on the extent of the damage, or it can start remodeling. So once we have this remodeling, this was stage A. Stage A in heart failure is when you have just these factors, and stage B now you have structural damage on echo, but the patient may be asymptomatic. Some patients, we've seen a few patients that have suffered from myocardial infarction, but they are still asymptomatic. So this falls under stage B. They have structural heart disease. For those patients who have valve disease, but they are asymptomatic, they will fall on stage B. And then now stage C and D is, stage C is whether they have present or past heart failure. If they have ever suffered of heart failure, then they come to this stage. And D is, of course, refractory heart failure. And in the end, the pumps start failing and they die. So that is how the heart failure occurs. And of course, in the middle of all this, the remodeling aspect, as we discussed before, the neurohormones are the ones that really play a big role. And what are the symptoms and signs of heart failure? I think I want you guys to tell me this. Any volunteer? Charles, now that everyone is quiet.
Yes, Dr.
Yeah.
So some signs may include breathlessness, orthopnea, paroxysmal nocturnal dyspnea,
Okay. Okay. So because of time, we'll proceed. So we have what you call typical symptoms, huh? And those are the symptoms that we usually have patients ask patients. Some people call it breathlessness. Some people call it shortness of breath. And especially when this shortness of breath is occurring in exertion. But it doesn't have to be like that. As long as somebody tells you they are short of breath, because when you're asking somebody, are you short of breath when you do some activities? Maybe they are already short of breath when they are at rest. So it will be difficult for you to really elicit that. And the other thing is autopnea and the paroxysmal nocturnal dyspnea. So those are typical symptoms that if a patient is having, it really points you to heart failure. But some patients will just come and say they are unable to exercise. And maybe they'll tell you they are just feeling tired, they're feeling fatigued. And after the exercise, they take a long time to recover and they may report ankle swelling. So these are typical symptoms. The other less typical symptoms is patients can just come with a cough that is occurring at night, and they can even come with bloating. They can come with loss of appetite. They can come with palpitations, dizziness, syncope. So some even confusion in the elderly. So there are some less typical symptoms, and then there are typical symptoms. And for the signs, these are the signs that at least when you see, you can almost say this patient is in heart failure. If you see elevated HIVP, if you see hepatocellular reflux, and if you listen to the heart and you hear at that as what we call the S3, and you have let's say laterally displaced apical impulse, depending if the ventricles are dilated. And the less specifics are things like weight gain, tachypnea, tachycardia, cardiac murmur. They can also come with wasting. We have what we call cardiac cachexia, where somebody just comes wasted. I think you've seen most of our patients with rheumatic heart disease, they come wasted. They can present also with ascites, and they can come with cold extremities because of their inability to perfuse. So these are the mechanisms. You see, why would somebody go into heart failure? You may ask yourself. So initially, when there is an insult, which we'll see in the next slide, you get this sympathetic activation. And as I was telling you, in the initial time, it's a good compensatory mechanism. There is mobilization of venous reservoir. There's a lot of blood that usually are in the venous system. So once you start getting vasoconstriction because of the sympathetic activation, then you start increasing the blood volume. But the problem is this heart is not able to pump out that blood, because initially, like for most of us, once we do this, then you start kicking in the Frank Starling mechanism, and of course you start emptying that ventricle. But in this case, they are unable to do that, and what happens is there is backward congestion, because if you are not able to empty the left ventricle, then you have just blood in the left ventricle, and because of that, there is increased pressure in the left ventricle, and because of that increased left ventricular end diastolic pressure, the left atrium is not able to empty, because usually you expect the diastolic pressures in the left ventricle to be very low, so that the left atrium, which is not a real, like if you look at the heart, the place where it has the most pressure is usually the left ventricle, but that is in systole. But then in diastole, it's supposed to be able to relax and drop the pressure so that the atrium can empty. And now, because of that, the atrium is not able to empty, and the backward pressures goes back to the lungs through the pulmonary veins, and patients will come with pulmonary edema, which is just because of that inability of because of the elevated end diastolic pressures in the left ventricle. And of course, over time, these are patients who will come with type 2 pulmonary hypertension because of that backward congestion. So there is also the other aspect of it, like because of the sympathetic activation, it can activate the renal system, the RAS, the renal system, and the RAS system will end up causing sodium and water retention, but this is a slow mechanism. But in the end also, it is increasing this volume, and these patients are getting more and more congested. So that is how you get patients coming with pulmonary edema in heart failure. And these are some of the precipitants of heart failure. So as upcoming doctors, if a patient is coming in heart failure, you need to ask yourself, what has happened? Especially those patients who are known to have heart failure and they have been stable at home. So you have to wonder, did something happened? And sometimes they may have gotten an acute coronary event. And also they may come in with arrhythmias. We've seen patients who maybe they were stable and then they come with atrial fibrillation. Usually in the way the heart is supposed to work is after the initial passive emptying of the left atrium, then you have what you call the atrial kick to help empty the left atrium. But then if somebody is in atrial fibrillation, they lose that and they are not able to empty completely their left atrium. More so if they are having rapid ventricular response, then they are not able to really empty, and the diastolic time is very short, and they can come with congestion. Other things are heavy block. Also, if they have uncontrolled hypertension, remember what was the stroke volume dependent was partly also because of the you needed afterload. So if the afterload is high, then these patients are not able to empty the left ventricle as well. And then now dietary non-compliance. We usually try to restrict fluid in these patients to at least about 1.5 liters, and even salt to a certain amount. So if they are unable to adhere to their diet, they can come decompensated. Other medications, especially here, NSAIDs. So if a patient comes, sometimes if, especially these elderly patients, they are having some arthritis, they are getting NSAIDs, and this can trigger heart failure. Anemia, hyperthyroidism, and all these other things, COPD exacerbation, I'm sure you know that. And if somebody gets something like pulmonary embolism. Also, acute kidney injury. Remember, you are depending on the kidney to function when you're trying to diurese these patients. So if they are unable to diurese, then they will come in heart failure. And then this slide will tell us how we will diagnose patient with heart failure. In our setup, if somebody comes with heart failure symptoms, as we said before, you don't have to have signs, but let's say they come with heart failure symptoms and signs, then you want to rule out to exclude if they really have heart failure or not. You are supposed to do a 12-lead ECG and these natriuretic peptides. Unfortunately, yeah, right now we have this available in CCO, but it is not available in the hospital. So but you can do this. If you do this, there are some ranges that you know for sure if this is the range that this patient is having heart failure. If this is not available, and as of course you're working the patient up for heart failure, you need to think of other things that can cause that can mimic heart failure. For example, are they having something in their chest? Are they having TB? Are they having a pneumonic process? So is there a pleural effusion? So you also want to do just a chest X-ray. So for every patient that you're suspecting heart failure, you have to do a chest X-ray, and you have to do the baseline metabolic panel, such as UECs, LFTs. You want to know what their sugars are. You want to know what their lipid profile is, and you want to know their thyroid. So thyroid. If a patient comes in past presentation with heart failure, kindly ask for a thyroid function test, because both hyperthyroidism and hypothyroidism can cause heart failure. And let's say if you do this and they are both normal, then diagnosis is unlikely, especially the PNPs. They are very sensitive, but we are not doing it, but I know this is for future. If one is abnormal, let's say your 12-lead ECG is abnormal, you go ahead and do echocardiography. In our setup, sometimes, as part of this, because we don't have these natriuretic peptides, we may just ask for a 12-lead ECG and do an echo as well. And then, of course, with the echo now, you assess the function. And I believe now we know what will be the cutoffs, what will we need if a patient is having ejection fraction of less than 50%, we can go ahead and call that patient heart failure, reduce ejection fraction. If they are having more than 40%, then we will need this natriuretic peptides, and also we will need to demonstrate that there is some structural abnormalities. And I will take you through these natriuretic peptides because it is what is coming up at the moment. So there are drugs that have just been just come to the market, and they are trying to attack this system. And in a normal situation, when there is a myocardial stretch, the ANP is for the atrium and the BNP is for the ventricle. So when there is a stretch, when the myocardium, it is produced in response to myocardial strength, and it can be cardiac distension, or we can say stretch. So once it is produced, it causes vasodilatation of the vessels, and it reduces blood pressure because of that. And if they keep this, it causes a reduction in renin production, and then reduction in angiotensin 2, and of course aldosterone, and then decreases blood volume. And also it increases EGFR and causes natriuresis. So this is a very good, these are good hormones, okay, in heart failure. So once these are produced, you can see it's making it's reducing the blood pressure, it's counteracting the work of the RAS system. So now in heart failure, we have staging and we have classification. Can somebody take me through New York Heart classification in heart failure? Anyone? Nicholas?
Hello.
Yeah, hi.
Yeah, okay. So the New York Heart Association classification has 4 classes. So in class 1, the patient has no symptoms with exertion and has no limitation in physical activity. In class 2, there is slight limitation in physical activity, but they are comfortable at rest. And then in class 3, there is a major limitation in physical activity, where the patient is only comfortable at rest. And in class 4, there is heart failure symptoms even at rest. Yeah.
Okay, thank you so much. Are you 60 or 40?
For there.
Okay, good, very good. So so that is what basically is said, only that I would like to correct that we call them ordinary activities rather than just physical activities. And so apart from that, you may want also, there's another staging. I think I've taken you through this, we'll see it. So you can see like these stages A and B, because patients doesn't have heart failure, they don't appear in the New York Heart Association classification. But then from stage C is when now we can start staging the classifying them that way. And this is what basically Nicholas has said. So we have no limitation in ordinary physical activity. And you know, ordinary can include running, playing basketball for those who are fan of it. And then now you have slight limitation. They get a little bit tired when they start climbing the hill, when they start running. And then now this patient is having, this person here is like getting tired, even cannot do that, but if he's resting, is okay. Now this is tired even at rest, as you can see. So what I want us now to go to management of heart failure. And this is depending on the stage of heart failure, really. And as upcoming clinicians, what I want to kind of tell you this, you guys today, is that you don't wait until somebody is symptomatic for heart failure so that now you can start managing them. No, you need to begin in stage A, and stage A we are saying these are patients with risk factors. And these risk factors mentioned before, key in our setup is hypertension, diabetes, obesity, and also if patients are using cardiotoxic. So these patients who are undergoing chemotherapy, kindly think about the implication in terms of heart failure. And here you just depending on the cause. If somebody is having atherosclerotic heart disease, you may want them to be on a statin. You want to control their blood pressure, and these are the medications that you may need to use, the ACE inhibitors, ARBs. So just address. Nowadays, like in diabetes, we've come, there's a new medication, SGLT2, that have been shown to also to be a can slow progression in heart failure. And for stage B, these are patients who have structural heart disease, and the medications also here. So as mentioned before, somebody has had maybe previous myocardial infarction. There are medications that you need to control this. And then the left ventricular hypertrophy, low for example, low ejection fraction, you need to address this. So these patients they don't have heart failure, but then they have already structural remodeling in the myocardium. And then for the stage C, you have patients who have heart failure. Now it can be either preserved ejection fraction or reduced ejection fraction. They are symptomatic. It can be that they are having the heart failure symptoms right now, or they have had it in the past. And in this case, unfortunately, for the heart failure preserved ejection fraction, we don't have much medications that we can use. So basically, it is addressing the risk factors. Because remember, the left ventricular ejection fraction, and this will include patients with the mid-range category. So you just address the risk factors and then use diuresis, okay, for these patients. And for in this other spectrum, you have so many drugs. We'll discuss this later. And then stage 3, the refractory heart failure. We'll discuss this also. So I put this slide, although there's been some change in this in some of these things, but I like this because it's telling you what to do. Like if a patient is symptomatic with heart failure, use ejection fraction, and we say this is stage C. Then you start them with an AC inhibitor. In our setup, the most used is enalapril. If they are not able to tolerate that, you can switch them and use an ARB, for example, losartan, and a beta blocker. Of course, a beta blocker, sometimes if somebody comes with overt fluid overload, you may not want to start it immediately, but you can start AC inhibitor depending on the blood pressure. And as they get a little bit dry up, you now can bring in your beta blocker. And if they're still symptomatic, this is now we have the new drug which is called angiotensin receptor and neprilysin inhibitor. We call them ARNI inhibitor. I'll take you to that slide later. This is actually the medication. So nowadays, it is one of the, it has been shown to improve mortality, and it is one of the drugs that is up here nowadays. And if the patient is still symptomatic, you now add aldactone. And if they are still symptomatic and all the time you're using diuresis, the Lasix, if they are congested, you're using Lasix all the time as you need. And if they're still symptomatic, you can add, and they're in sinus rhythm, and the QRS is very prolonged, and you can consider what you call cardiac resynchronization therapy. This might be too high for you guys, but I know these are part of the advanced heart failure therapies. And if their heart rate is elevated, you are on your maximum dose. You're supposed to titrate these drugs to the maximum. You can add what we call ivabradine, so part of the new medications that have come. And if they have resistant symptoms, you have your digoxin. I know some of you start digoxin as the first drug. Okay, so now with what I was showing you was about the European guidelines. Now we have new guidelines also in the ACC, the American College of Cardiology, because of the new medication that has come. What I was telling you, the angiotensin receptor neprilysin inhibitor. So this is a new medication, and you can see it is come up here on the list of medications that you start first among patients with heart failure, and you do not combine. So it's either, because this is already is an AC inhibitor, so it is either this or ARB, and then you add a beta blocker. So those are the three drugs that are on top of your list, either of these. But if you are, the challenge with what we call ARNI is the fact that it is costly and it's still yet to get to the market. So we are still remaining with the usual AC inhibitor and ARB. And as depending on the renal functions, adding aldosterone, always ask yourself, what is the renal function? So your TFR, you need at least TFR to be more than 30 mils, and for you to add. And you also need to look at your potassium. The problem with aldosterone is it causes hypokalemia. So you don't want to start somebody who has a potassium of 5 with aldosterone, okay, antagonist. And also you can add this SGLT2, as I was telling you now, this is what is in the market as part of heart failure therapy. And you can always use the diuretic agent as you want. And for patients, you may have some patients who are still on these medications, and they are still symptomatic and their blood pressure is good. So you are already in the maximum doses. So remember, the key is to titrate the medicine to maximum doses as tolerated. If you are on the maximum doses and they are still symptomatic, you can consider actually adding hydralazine and isosorbide nitrate. And here again, as we had said, somebody in sinus rhythm and they are on maximum dose of a beta blocker, they're still symptomatic, their heart rate is more than 70, you can now add ivabradine. And this is how the sacubitril valsartan, what we call the angiotensin, the drug that I was talking about, this is how it works. Remember, we've discussed about the nice natriuretic peptide system that causes a very good effects for the heart failure. It causes natriuresis, so you mean you diurese, you vasodilate. It also is antiproliferative and reduces sympathetic tone. But then this BNP is degraded by neprilysin. And the drug that has come now is a drug that will affect the system to avoid the degradation of this neprilysin, to block this neprilysin so that it avoids degradation of the BNP, so that the BNP can give you this effect that you want. And then on the other side of the spectrum is of the drug, because it's a combination, it's a molecule that has this drug. There is this LCZ 696 and valsartan. And this is the valsartan aspect of it affects the renin-angiotensin system. And remember now, like if somebody was on ACE inhibitor and you want to change to this drug, you may want to give some time for the ACE inhibitor to be removed from the system, but this might be too high tech for you guys. But what I just want you to check on is if somebody was on ACE inhibitor and you want to change to this drug, you may need to give them some hours, at least 36 hours or 72 hours for the ACE inhibitor to come out of the system. And of course now, so this is a good drug working for us in two ways. And this is why it is becoming one of the key drugs. So as we proceed, I would like somebody to just tell us what are the drugs that causes improves mortality in heart failure. And I'm gonna ask Amwata.
Yes, doc. So the drugs that improve mortality are the ACE inhibitors, stroke the ARBs, and also the beta blockers.
Okay, any other drug? Metet? Metet, are you here? How about Bruno?
We also have diuretic, aldosterone antagonists, and beta adrenergic blockers.
Okay, I think Bruno, you are fourth year or sixth?
Fourth year.
Okay, good. Yeah, so this is, if you don't come out with anything from this class, I want you guys to know which drugs improves mortality in heart failure. And yes, beta blockers. Now you can see we are having the sacubitril valsartan, okay? And then the ACE inhibitor and ARB, okay? So this sacubitril valsartan is what I was calling, you call them angiotensin, angiotensin receptor neprilysin inhibitor, okay? ARNI. So this is what is new. This is what has been there, okay? And this has been shown to improve mortality. Also beta blockers, and then now mineralocorticoid. Lasix doesn't improve mortality, but it helps you to control the patient's symptoms. This is more advanced for you guys, but you also need to know that sometimes you may need to put an ICD, what we call implantable cardioverter defibrillator, to avoid these patients who are in heart failure because of their low EF and the remodeling in the myocardium, they can get the tachyarrhythmias. So sometimes you may need to use like devices, okay? So these are the devices that can improve. There is also what we call cardiac resynchronization therapy. If their QRS complex is very wide, it means, you know, in terms of the conduction issues, they are not, it's not synchronized. The left and right ventricle are not synchronized. And sometimes you may need to put this cardiac desynchronization therapy. This is more advanced for you guys, but I want you to know that there are devices that you can use and they also improve mortality. Now, also transplantation, of course, and this is another device called left ventricular assist device. Hydralazine and isosorbide, the nitrate, in some studies, it shows that it improves mortality, but here they have talked of improving morbidity. And digoxin, okay? So digoxin is an old drug that was shown to improve, to decrease the rate of hospitalization. So it helps in morbidity, but not mortality. The same thing with ivabradine. But I want you guys to come out of here at least knowing these three aspects of it: the ACE/ARB, sacubitril valsartan, or what you call ARNI, and the beta blockers and androstenedione antagonists. And these are the medications that you can use. In our setup, we like using enalapril a lot. And you start with 2.5, and then you can titrate all the way to 10 to 20, okay? So you always start low. Carvedilol as well for the beta blocker, you start low at 3.125 twice a day, and then you titrate up. And another drug is metoprolol, which you titrate up as well. Losartan and spironolactone, which is basically aldactone, and now the ARNI, which is sacubitril valsartan. And for the diuretics, you can use the furosemide, which is Lasix. You start also low at 20 to 40, and you can titrate up. And the other drug is the thiazide diuretic. You can start. Sometimes we use metolazone, but usually the problem with this is electrolytes. And in conclusion, so heart failure is a clinical syndrome, okay? And it is classified into 3 types, and that is what you guys are expected to know. And the main pathophysiology is just maladaptation of the neurohormonal axis, which leads to remodeling. And management of the risk factors of heart failure is very key. And you treat heart failure using a stepwise approach. Like, I don't expect you to put all the drugs together. You can start with one drug as you titrate. If the blood pressure is very good and the patient is dry, you can start with an ACE inhibitor, low dose, and a beta blocker as well. And then you have to keep titrating. And then now you see if you need to add another medication. So it's stepwise. And the drugs that have been shown to improve mortality are, as we had mentioned. And for the heart failure with preserved ejection fraction, it's a challenging disease because there is no drug that has been shown to reduce mortality. But what you want to do is to address the risk factors and to use diuretics if they are congested. So thank you so much. If you have any questions, I'd be glad to take some. Any questions? Back to you, Charles.
Excuse me, Doc, I have a question. I have 2 questions.
Yeah.
So first of all, I know we just talked about the symptoms. Can we use the modified Framingham criteria to qualify heart failure? And then the second question, though not related to chronic heart failure, in patients with acute decompensated heart failure, what exactly is the role of morphine?
So morphine is, so I'll start with Framingham. So personally, I don't use Framingham. I try to use this way, but I find it easier, okay? And so sometimes you may need to simplify, like, are you going to get something more additional if you use the Framingham? Because this is what is coming up a lot from you guys. Even the last group, they asked the same question. So personally, I just use this borrowed from the European Society of Cardiology to approach patients with a heart failure. As per the role of morphine, of course, morphine is been shown to, in acute heart failure, morphine, it's part of what you use to treat pulmonary edema. It causes a vasodilatation, especially in the pulmonary vasculature, and that is what helps the patient get relief. If somebody is in acute pulmonary edema, there's usually a mnemonic. You have what you call MONA, so it's morphine, oxygen, nitroglycerin, But of course, the nitrates will depend on the blood pressure. And then what was the yeah, and then of course you diurese them. Okay, so it's so for the morphine, it's just to relieve the pulmonary congestion. And what was the other question?
There are just those two, and you've answered them. Thank you.
Okay. So the pathophysiology of high output heart failure. So high output state, first of all, there is the tachycardia aspect to it. Okay. So for example, high output is usually associated with something like hyperthyroidism. And as I'm sorry, I'll have to leave at 9 exactly, so I may not take more than these questions. So if somebody is having that tachycardia, then of course they start getting, sometimes it's because of the hypertension itself, sometimes it's because of the tachycardia. And after some time, they are able to, you know, initially they are able to, the ventricle is functioning normally, but as time goes by, it's just getting also dilated and failing. Just because this high output also is associated with elevated adrenergic hormones, all these sympathetics and what we've talked about. So that is what happens. So they usually have tachycardia, they have hypertension, and initially the ventricle is able to adapt, but as time goes by, it starts failing. So that is what I could say about high output heart failure. So thank you very much. If you have further questions, you can always reach me. Otherwise, I love to end here. So thank you, everyone.
Thank you so much, Doc, for the presentation, and have a good Easter holiday.
Okay, you too, thank you.